we don't know very much about this new variant. But based on what we do know, how concerned should we, investors, the general public be?
Well, look, on the one hand, it has mutations that have been associated with immune escape from the protections offered by vaccination, also the protections offered by prior infection. And the epidemiological data so far, although we have very little data on the epi and the spread of this in South Africa, does seem to suggest that it may be more transmissible. In particular, it has major escape mutations on each of the 3 dominant epitopes that we produce effective antibodies against. That said, it's important to remember this does not mean that this new variant will fully escape the vaccines or even meaningfully escape the vaccines. It may be a situation like we had with 1351, the beta variant, where the vaccines are less effective, but they're still effective enough when you have widespread exposure to the vaccines across a population. Remember, with that variant, 1351, the vaccines, a fresh vaccine was only about 75% protective. But that kind of protection, if that's what we end up seeing here, is still going to be quite sufficient in being able to use the vaccines as a tool to control the spread of this, given all the other immunity we have in our population and also the advent of drugs that will be coming on the market. Remember, someone who's walking around right now with a vaccine that's 6 or 7 months old probably only has about 50% protection against the Delta variant with that vaccine. So if we still have 75% or 70% protection against this new variant with this vaccine, that's still going to be quite protective. Finally, the final point here is that when you have a variant that has this many mutations in it, as this one does, there is some suggestion from the literature that it becomes less contagious. And so we may see this spreading in pockets of the community in South Africa. But on the whole, this may be a less contagious variant because it's acquired so many mutations. And that's what we've seen in certain cases in the past. So I think it's early days to call that this is going to really change the nature of the game, at least here in the United States, where we have a lot of immunity. The risk is that we get through this Delta variant, we start to see prevalence levels decline very sharply, and then this new variant starts to get a foothold and changes the equation for the spring or the summer, what should have been a very quiet spring and summer with COVID. I don't think that's going to be the case. I think it's way too early to draw that conclusion. I think, if anything, that is the risk, though, that this is something that we have to deal with 3-4 months from now.
Right. Dr. Gottlieb, you went on record numerous times and said that you thought that Delta would be the last major variant that we would have to contend with. Do you stand by that?
Yeah, look, I still feel that way because we don't know as much about this. What I said specifically was Delta would be the last major wave of infection, barring something really unexpected with this coronavirus. I think it's way too early to conclude that this is that unexpected thing with the coronavirus. We don't know how transmissible this is. It's likely to be less transmissible because it's accumulated so many mutations, but we don't know. Again, the epidemiological data is very early. They're oversampling for it right now in South Africa, so you're probably getting a skewed picture of its prevalence. And we also don't know how effective the vaccines are going to be. And if you had to put down a point estimate right now, looking at the characteristics of this virus relative to what we know, and we don't know a whole lot, you would estimate that you're not going to lose the vaccines here, that there may be some diminished vaccine efficacy, but they're still going to be protective against this variant. And so if a fresh vaccine is still 70% protective against this variant, it's not all bets off. What it is going to do, though, is increase the pressure to get people boosted, get the unvaccinated vaccinated, and vaccinate kids, because the more that we can get more immunity into the population and more robust immunity into the population, the more protected we're going to be. And the boosters become very important because diminished vaccine efficacy becomes more of a risk if you have a strain that can better penetrate the protections offered by the existing vaccines.
Down 927 now on the Dow. When will we know the answers to these questions? How long will it take to know whether vaccines do hold up, for instance, against this variant?
Yeah, there's some in silico, so some modeling data floating around right now among virologists that suggests that you don't get complete escape with this. That's way too early to draw conclusions from because we don't have good enough in vivo data in humans to really have accurate models. We'll have neutralization studies in about 2 weeks, meaning that we'll have studies from laboratories showing how well the complement of antibodies induced by vaccination neutralizes virus. I would expect to see some decline in the neutralization given the characteristics of this virus, but I wouldn't expect to see a situation where you get something that falls off a cliff. where the existing vaccines just aren't effective against this, aren't clinically effective against this. So I think we're going to retain some potency and enough potency in a country like the United States, where there's a lot of pre-existing immunity to protect against another huge wave of infection. And that's really the risk, that you see prevalence decline as we get into January and February. And then we have another sort of B117 situation where you saw prevalence coming down last winter. And then when 117 started to circulate, all of a sudden we got that second spike in March. And this kind of ruins the spring. Too early to say that's what's going to happen. I think that's sort of a worst case right now. But I think it's way too early to say that's what's going to happen. And the other thing is, people who've been infected with Delta probably have pretty good protection. And people who've been infected and then subsequently been vaccinated, all the studies that we've done show they have very robust protection against these new variants. And so they're in pretty good shape as well.
What would you say about border controls, which are already starting to come back? We've seen the UK, Europe, Israel, a number of countries already putting flight bans and suspending flights in place against places like South Africa and other southern African countries. Is that a prudent step? Should the U.S. be doing that?
I think it's a big mistake in the long run because it's going to discourage nations from disclosing these things early. I mean, South Africa was very early to disclose this. We're dealing with very preliminary data right now. They did the right thing from a global standpoint. And if the result for being early and disclosing this information is you get economically punished, countries are going to become more reluctant. At this point, this variant probably is globally distributed. I think putting in place restrictions on who can travel, for example, requiring people to be vaccinated to come into the country, makes prudent sense. But closing down travel in a wholesale fashion, as we've seen some nations do today, I think that's a big mistake both in the near and the long term.
So it sounds like you are looking at the silver lining here. I mean, it's important to hear from you. We have not heard that before, that more mutations potentially could make it less contagious and less spreadable. So ultimately, Dr. Gottlieb, do you still think the end of the pandemic is near? You've talked about as soon as January. Is that still the case?
Yeah, look, people are concluding that this may be more transmissible because of the rapid growth in cases, but we don't know whether that's a founder's effect. You've had an outbreak of this variant in particular regions. Vaccination rates are low in South Africa. They've deployed different vaccines than us. Many people who've gotten the mRNA vaccines are only partially vaccinated. At least half of the people who've gotten the mRNA vaccines are only partially vaccinated. And they're now oversampling for this because they can detect it on PCR. So I think you're getting a skewed picture of the growth of this. That doesn't mean it's not more transmissible, but I think right now concluding that it's way early to conclude that. I still believe Delta is the dominant variant here. We're going to be through this Delta wave probably by January. You see prevalence declining sharply in the south and the southeast, the Pacific Northwest. It's starting to come down in the southwest right now, and states like Colorado. You're still going to see a Delta wave in the northeast and the northern regions. The Great Lakes regions are still coming up. But we're closer to the end of this Delta wave than the beginning. So on the back end of this, prevalence will decline. I think barring, again, something unexpected, we're going to be in a more endemic phase with this. I think the risk of a new variant like this emerging is that it kind of ruins that picture heading into the spring. By March, we should have been out of this. And if this is something that's more transmissible and pierces the vaccines, it could increase prevalence coming into March. I think it's way early to conclude that right now. It seems like some people are drawing that conclusion. I think this is very speculative at this point.
Well, let's hope you're right on that. Down 875 on the Dow. You know, we've talked a lot about the potential to evade vaccines. What about the treatment toolkit that we have developed here, thanks to companies like Pfizer that you're on the board of, Merck with the pills? We've got monoclonal antibodies from Regeneron and Lilly. What is the likelihood those kind of treatments hold up to protect us against this new variant?
Yeah, and that's the other point. This won't defeat our technological toolkit. So Western countries that can deploy those technologies are going to be reasonably well protected. First of all, we can re-engineer the vaccines very quickly if this is something that truly is threatening. The small molecule drugs, the oral drugs, including the pill by Pfizer, should work against this, and the pill by Merck, given some of the testing that we've done historically with that. The antibody drugs, it looks like the Vir antibody and the antibody by AstraZeneca will hold up quite well based on the laboratory evidence. You could see the Regeneron antibody and the Lilly antibody put at risk, but those companies also have second and third generation antibodies in development, and they can re-engineer those drugs pretty quickly as well. So we're not going to lose our armamentarium against this new variant. I mean, it may put a wrench in the trajectory and what we need to do in terms of how we deploy those things and put new urgency on getting people vaccinated. But we're going to be able to stay ahead of this. I worry about the rest of the world where you can't deploy those technologies very quickly, including in South Africa where you have under-vaccination that could have opened the door towards the epidemic spread of a new variant like this.
And just to be clear on how long it could take to modify a vaccine to address a new variant, if this one does evade the vaccine, I think Pfizer mentioned today 90 days, which is very short, I know, probably in the scheme of developing vaccines. But is there any way that that can be even shorter? And how does that work? Does it have to go through clinical trials again, or can it just be re-released like the flu shot?
Yeah, it'll go through trials where you expose people to the vaccine and you make sure they're getting sufficient levels of antibodies that are going to be protective against this new variant. So it's not going to require a big outcome study like previous vaccines, probably. I think that this would be done with so-called, immunogenicity studies. That's sort of 90 days, 100 days from initial coming up with the construct to commercial scale production. And companies are already coming up with the construct. So I think we're going to be in a position, if we need to be, to have vaccines widely accessible in time to deal with any wave from this new variant. If this does start to threaten the United States, it's probably months away before we see a real uptick in the cases of this new variant. Given just some of the past timelines with how B117 spread and even the Delta variant, it took a sufficient amount of time. And we're on this very early owing to the good work of the epidemiologists in South Africa. So we have a very good early warning, which shows the world's getting better at this. So I think that there's sufficient time, if we need it, to, develop and manufacture a new vaccine. And again, I don't think we're going to lose these vaccines. And so if you have a fresh vaccine, if you've been recently boosted or you're newly vaccinated, you're probably going to have pretty good protection even against this. I mean, we'll see where it comes out. Maybe it's going to be 70% protective, maybe 75%. Even if it falls below 70% protection, that's still pretty good protection. Again, remember, someone who's walking around who was vaccinated 6 or 8 months ago with 2 doses of vaccine probably has 50% protection against Delta right now. And so we're seeing levels of Delta infection come down around the country, even with that level of protection from vaccines. And so even if you're in the 60% range, that's still pretty good in preventing, a widespread epidemic of this new variant. So boosters are going to become more important if, in fact, this does start to spread.
Yeah, get your booster. Dr. Scott Gottlieb, we are lucky to have you. Thank you so much for all the information today.
Thanks a lot.